This has come about because over the last year I've been confronted by new treatments, new requirements from Pharmac, and I thought it would be useful for you guys to see some of the drops that I'm using for surface treatments for tumours, but also some other drops that you guys might use or use as an alternative to steroids in your practices as well. So there are more and more eye drops coming online. People are always publishing this or that drug which has been applied as an eye drop, and I've been quite surprised during the year of what has turned up as being able to be used as an eye drop. Pharmac has chopped and changed a lot, and they're getting more and more aggressive in trying to get the cheapest drug, just in having one drug and then the old drugs out. The result of some of that, and also at the CDHB, issues with not being able to formulate drugs at the DHB. We're having to order them from Auckland pharmaceutical companies, so the cost's going up for patients. Some of the drugs I want to talk about are interferon, 5-FU and mitomycin, which I use a lot for surface tumours, but they also have a lot of other uses for anti-scarring, glaucoma surgery, corneal surgery, refractive surgery as well. Cyclosporin, so in the United States, Restasis is hugely widespread, and that's used for dry eye, so it's one of the most common prescribed eye drops in the States, and yet we have very limited access to it. It's named person, Pharmac authority only. Should we be using it more? Nepafinac, so some of you may have already been prescribing this. This is the new non-steroidal that's on the Pharmac schedule as of February 2021. Because we haven't been able to get Voltaren, which has been the Pharmac funded drug, this is now fully funded, so you can prescribe it if you want, so I'll tell you a bit about that. Tacrolimus, that is, it's really a steroid-sparing immunosuppressant, an alternative which I've had the fortune to use in one patient who actually requested it for themselves, so they were teaching me. Avastin can be used as an eye drop, so it seems to cure everything in ophthalmology. I use quite a bit of injections of Avastin subconjunctivally for getting rid of corneal vessels or stopping them from coming. It's also useful subconjunctivally for stopping pterygiums growing back. If they start to get those little fronds, you can actually halt it, but I thought I'd take a look very briefly at the usage in eye drop form. And then just briefly mention of some antibiotics that you can get topically. So my go-to drug for squamous neoplasia, perhaps after it's been excised or perhaps you've already gone to mitomycin once, is interferon eye drops. You may not have had any contact with this at all, but it's extremely well tolerated. And very useful and has good evidence of resolving squamous neoplasia. We had a lot of issues last year not being able to get it, and the cost has gone up ×4 through Pharmac and the DHB's machinations. So what are interferons? They are basically antiviral cytokines, so messenger proteins. And they're released from immune cells when they come into contact with viruses and other cells, so tumours as well. And what they do is set up the other immune cells to fight those viruses better. So it's like a sort of positive type of chemical that you can put into the eye. And they're called interferons because they interfere with viral replication within cells. It's an old name. There are 3 broad categories of interferons, and they're categorized by which cells release the interferons and what cells make them. So alpha is produced by blood white cells. Beta is produced by tissue immune cells and fibroblasts, so sort of scarring and active cells within the tissues. And gamma is produced by specific T cells in the blood as well. And in medicine, they all have their uses. So the alpha interferons have been one of the mainstays of hepatitis C treatment until the newer biologics have come along. So you may know that Hep C is just about curable now, which is awesome. But interferons are now Plan B. They're still on the Pharmac schedule, which is why we can still get it for people for use in hepatitis B, melanoma, and HIV conditions. The beta drugs are used for MS, and they do have quite a positive effect. They're extremely expensive. And gamma, also known as interleukins. Mainly I've come across these where a rheumatologist has given us a talk at the hospital and I have no idea what they're saying. And they say interleukin 1 or 6 does something, and I was surprised to find out that interleukins are a type of interferon. So I don't know much about them. As you might expect, side effects of interferons are kind of like the side effects you get when you've got a virus. So your body's response to the virus is driven by the interferons. You get a temperature, you feel rubbish, and they're basically the side effects of having intravenous or weekly injections of interferon, which is how it's administered systemically. There are some severe adverse effects of that systemic administration, but really not seen with eye drops, although the evidence is pretty limited. So what's now on the Pharmac schedule is actually pegylated interferon, and that is the addition of polyethylene glycol. So apparently, so I've learned during this talk, this is quite a common way of adding a molecule onto an active drug. When you administer it into the body, it changes how it's absorbed and may give it a longer half-life, or there may be less reaction to it. And I was interested to see that polyethylene glycol is basically cysteine eye drops. So when you mix interferon with polyethylene glycol, that's now what we're able to get in an eye drop form. So maybe that's a win-win, a little bit of lubrication as well. So we can now get that. It's pretty expensive, $400 a month, and insurance may or may not cover it, but if you put people through the DHB is obliged to pay for it because it's on the schedule. So systemically, and I've gone through this because we've changed from alpha 2B to alpha 2A and now pegylated alpha 2A. I wanted to see, is there any difference? Is it going to be effective for what we use it for in ophthalmology? There is very good evidence for its effectiveness in hepatitis C, and that the subtypes of interferon are basically equivalent, so the A's and the B's. There are some studies on essentially what we're using now, which show good effectiveness and good tolerance. And there are very good trials, which I think I've got on a slide coming up, dating back 10 plus years, showing it's very effective against ocular surface squamous neoplasia. I'm going to talk about some of these lower points soon, and that the alternatives are mitomycin and 5-FU, which have been long used in ophthalmology, but those drugs are cytotoxic, whereas the interferons are kind of good drugs. They help your immune system to kill off the tumour cells. Probably the main problem with it is it's really expensive, although it's still now only 1/5 the cost of Eylea. So being an anterior segment person, I say we should have it. So this is some of the evidence. So Laurie Hurst, Brisbane ophthalmologist, who's sort of the pterygium guru in squamous neoplasia, proved that it's basically just as effective as mitomycin and 5-FU. The course of interferon is around about 5 months on average till resolution of a squamous neoplastic lesion. but it's very, very well tolerated. So mitomycin gives people red eyes, interferon basically doesn't. So that's why I like it. We're now thinking maybe we should be using more 5-FU just because of the cost. It hasn't been our go-to drug. So a drug you'll probably be more familiar with, at least in letters, in terms of ophthalmic use, is mitomycin C. This is a cytotoxic, so it stops replication, it kills cells that are rapidly dividing. It's originally discovered, released from a soil bacterium, and it stops DNA synthesis. So a lot of the chemotherapy drugs, which mitomycin is, it's used to treat melanoma, basically stop rapidly dividing cells and kill them. And so the mitomycin's a classic sort of cytotoxic chemotherapy drug. In terms of the eye, so it stops activated fibroblasts, keratocytes, causing scarring. It also kills rapidly dividing neoplastic cells, so that's why we use it. Aside from surface squamous neoplasia, you can use it for surface melanoma. It is effective. And you can use it for a variety of other things, to stop scarring after laser surgery, to stop scarring with a recurrent pterygium, and you can use it in that fashion by soaking it onto the eye where you've got the scarring or where you think there might be more scarring for around 30 seconds or so, and it basically kills all the fibroblasts, all those rapidly dividing cells, and stops recurrence pretty effectively. Here are some of the uses. I love this term, bleb resurrection. And it's pretty true if your trabeculectomy's dead and the pressure's going up and you really don't want to do another one and you don't want to do a tube, you can try injecting mitomycin and try and getting it going again. The frustrations of glaucoma surgery. The rest of it, I think I've briefly touched on. I asked Rebecca if she'd used it, and she has used it in DCR as well, just to stop adherence and scarring afterwards. So this is routinely used when you see trabeculectomy mitomycin C. What does that mean? What we used to do is you lift up the conjunctiva where the bleb's going to be and stuff a sponge that's been soaked in mitomycin under there for 2 minutes. A lot of problems with that because yes, you're stopping scarring, so you don't want the bleb to heal, so it doesn't work. But you also make that bleb very friable, where you don't want to leak where you're stitching it. It makes the tissue very weak, and it makes it very thin. Some of those old mitomycin blebs are quite horrible. They're blistered and they start leaking, and it's a problem. So what we're doing now is not doing that. We're injecting before surgery, back away from the limbus. And it seems, to me anyway, it seems a lot better. Still get a good bleb in a better location. In PRK, so surface laser, there's very good evidence that it minimises the amount of haze that you get. So haze used to be a problem years ago in the heyday of refractive surgery, especially if you're treating more than 6 diopters, but maybe more than 3 diopters of myopia. The more ablation you do, the more inflammation and the more haze you get. So that's a nice word for scarring on the cornea after laser. And what they showed in some pretty thorough trials is that applying that for 12 seconds onto the cornea is just as effective as 2 minutes, which is interesting. Mitomycin as an eye drop is not well tolerated. The usual dose is 4 times a day for a week, and then have a rest for a week. 4 times a day for another week, have a rest. Maybe you need more rest, and then if they're really up to it, a further week. It causes a red eye, a horribly red eye, usually into that 2nd week of treatment. So usually a week's well tolerated. In the 2nd week they start to get a red eye, and It's a good drug if you have a melanoma or a invasive squamous cancer on the surface of your eye. So people tolerate it because you tell them, look, it's hurting your eye, but it's hurting the tumour more, and they'll put up with it. But it can be relatively severe. It can stop some people from having it. Also, it is toxic, and I believe if you have more than 3 weeks of it, you start killing off your limbal stem cells for your cornea. So I don't like using any more than about 3 weeks of it. It is so effective that you can get no healing. So you kill off all the cells, and you can get a melt in the peripheral cornea or even on the sclera. Bleb problems, and these things, look, they're pretty rare. I really haven't seen any of those. I think you'd have to use a massive dose or overuse it. Yeah, so that's mitomycin. It's a very commonly used drug in ophthalmology, and it's sort of much more aggressive than the interferon that we use for longer courses, or in people who've already done mitomycin and they get a recurrence of their squamous neoplasia. We've already biopsied it, we know what it is, then interferon's a great drug. 5-FU, also very widely used in ophthalmology, is somewhere in between mitomycin and interferon, so it's not too horrible like mitomycin. It only knocks off actively dividing cells, so 1/3 of the cells at a time, and they can make a comeback later, but it is a cytotoxic. It's used in treatment of cancer as well as a chemotherapy drug. Yeah, so the quote is it's around about as 1% as potent as mitomycin, but that's still potent. So 5-FU was used before mitomycin for glaucoma surgery, and used to modulate who you gave it to and who you didn't give it to based on how old they were, how likely they were to scar in terms of a bleb. So an 85-year-old, should you have to do a trabeculectomy on them, you wouldn't do anything because they don't scar much, they don't heal much. But if you had to do it on a healthy 36-year-old, someone who's got an inflammatory condition, you might use my 5-FU for 5 minutes. So you're sitting there twiddling your thumbs while the 5-FU soaks in. We used to use this routinely. If I saw a pterygium coming back, I would inject 5-FU around the little fronds coming in, but Avastin is just better. So don't really use it for that anymore. It's very widely used now, mostly after trabeculectomy. If you need to do something to the surface of the eye, so needle a bleb or lift something, or something that's going to be inflammatory, if you give a wee injection of 5-FU, it damps down that inflammatory response, and hopefully you still get the bleb working. I think I've just said all that. So it also is available and easily used as an eye drop for these surface problems on eyes. It's well tolerated, a lot better than mitomycin, and its effectiveness is somewhere in between interferon and mitomycin. So my feeling is with the troubles and the cost we're having with the interferon now, we're going to see a little bit more usage of this, definitely in Canterbury anyway. So in summary, these 3 eye drops are kind of the spectrum that we would use in ophthalmology for treating surface tumours and stopping scarring. So revisiting pterygiums, modifying trabeculectomy blebs. They are all effective and they all have their place, and we can still get them all, but it is getting more difficult to get that interferon. I think we'll take questions at the end, if that's okay, unless anyone's got a burning question about these ones now. Great. So I'd like to talk about Napafinac. So that is the non-steroidal that's now on the pharmac schedule, and you can prescribe it and it's fully funded. So until now, Voltaren's been the pharmac funded drug of recent years anyway. But as you probably all know, you basically can't get it with COVID delivery problems. New Zealand went out of stock in about December, except for the pharmacy at St George's. Somehow they had a wee stockpile, so I've been able to still get a few patients through there. So what pharmac has done is found another one that used to be named person special authority only, so there must have been a bit around and a supply chain, and they've just put it onto the schedule. What I discovered after prescribing it, just the same as Voltaren, is that actually it's different, and it only needs to be once a day. So this has been reasonably well studied. There's two strengths, and the 0.3% is the one we have in New Zealand. It's the stronger dose, which is only once daily usually. They're the same cost, so I don't know how pharmac works, but there seems to be, whether that's the true cost or not to pharmac, I'm not sure. There's behind the scenes stuff we don't know about. You can still get Acular, but as you probably know, it's not funded, and that's another alternative. So non-steroidals are having more and more of a place in ophthalmology, in pain and anti-inflammation as well. So just we talk about non-steroidals. So most of the original studies were done on Acular, so that's ketorolac, and they were done about post-op macular edema, CMO. So there were some really good studies that showed the combination of ketorolac with prednisone was better than prednisone alone, and it was better than nothing in resolving post-phaco cystoid macular edema, which, as you know, is reasonably common. It's actually cheaper and for more, and I don't know why it's not the funded drug. So if you know, let me know. Anyone's on the pharmac advisory board. Is there one for optometry? Is there like a pharmac representative? Because I think Malcolm used to be on that for ophthalmology for a long time. Yeah. So the new one, there was, it's been around for ages, so 15 years or so, and again they studied that versus ketorolac versus placebo, reasonably good trial structure, randomised controlled trials, and they showed it was basically just as effective. Subsequent to that, it was studied in post-cataract pain and at an increased dose, and they found that once a day dosing was non-inferior, but actually there was a trend to it being slightly better than the 3 times a day dosing with the weaker dose. So you can use this once a day, which is great. I've been prescribing it for post nasty things to corneas, which really hurt, anything that needs a debridement or trigem, as once a day for a period of time, plus once or twice extra if they've got that acute pain initially, and I think that's reasonable. If you look at the pharmac schedule, which for this talk I have actually done, I haven't done much before, you see all these stars down it, and this is online, you can just Google it. There's a little guide down here as to what that means. So the little stars mean 3 months or 6 months dispensed all at once. So I got quite excited thinking, hey, we can prescribe 6 months. In the old days, a lot of the drugs had the triangle, and you had to write certified exemption on your prescription to get 3 months, but all the eye drugs are either star or nothing now, which means mostly they can be dispensed 3 months all in one go. If they don't have the star, or if your pharmacist insists on prescribing 1 month at a time, which a lot of them do, you can apparently write on the prescription recommend extended supply as discussed with patient, or if someone's going on holiday, you can write that on the prescription and they then have to dispense a 3 months worth all at once. So when you dig deeper into that 6-month thing, where is it? With the star, it's 90 days, but 180 days only for the oral contraceptive. So on every page of the schedule, they've got this 3 months or 6 months, but in fact it's only the oral contraceptive, which is 6 months, which I find bizarre. They should have a different symbol for the oral contraceptive. Oh, that's unusual. Right, moving on to cyclosporin. So this is Restasis, which you've probably heard of for dry eye. It's very widely used in Australia and the US, hugely used. And there's no barriers to that like we have through Pharmac. This is a so-called organic immunosuppressant, so one that's derived from bugs or naturally occurring. And in this case it comes from funguses or fungi. So there's a couple of species that make cyclosporin, and what it does is suppresses the T-cell function in your body, so it's an immunosuppressant. It can be used as an alternative to prednisone. So I've got more and more interested in this, A, because people refer me people with horrible dry eye that hasn't got better with a number of other things, but also as an alternative to steroid. People may have a pressure rise, or they're young, you don't want to give them cataracts, etc. It's widely used as a systemic drug for organ transplantation to stop rejection, and also on our front to stop corneal rejection. And it's pretty readily available. There are good studies showing there's no pressure rise with it, as opposed to prednisolone, and they don't seem to get cataract either. So in terms of dry eye, who should get it? Is it useful? There are actually a huge number of studies, and many of which are conflicting and don't show much benefit over placebo or over just lubrication. And I guess this is why Pharmac hasn't made it readily available in New Zealand. It is pretty effective in Sjogren's syndrome, and it kind of makes sense. This is a definite autoimmune condition, and you're putting in an immune suppressant. So for specific people who you know have got an inflammatory or immune component, it definitely makes sense. I have never used it for transplants, but other people have. It's an alternative to steroid for those subepithelial infiltrates post-adenovirus, or tigesins, which are probably post-viral subepithelial infiltrates. We just don't know which virus. And it's also been applied in vernal, so quite a wide range of uses, and it is a drug that's available. More recently, someone's gone and done a pretty good study on blepharitis for cyclosporin. Now, we all know that blepharitis gets a bit better if you give steroids, so it makes sense that in some people, if you give a different alternative immune suppressant, it'll get better as well. It's just a hell of a lot dearer. So how's it used in terms of Restasis? It's basically a beady eye drop, so twice daily. You need to use it for several weeks for the effect to kick in. And during that period, usually you want to be giving them some steroid as well. So for me, I would direct this as a 3rd or 4th line treatment for dry eye in patients where there is some sort of autoimmune or at least an inflammatory component. And continue lubricating so we don't just use cyclosporin and stop all the other stuff that you do for these terrible dry eye people. But it certainly has its place, and certainly if they've got Sjogren's, and you're struggling, it's a really good next step. So for those of you who are familiar with Cochrane reviews, It seems like every single Cochrane review nowadays says that there is insufficient evidence to prove usage for just about every drug out there. So if you read enough studies and apply very, very strict criteria to what you count as level A evidence, about half the things we do in medicine are no evidence. But if you look at those very specific studies where it's been used as an immune suppressant, properly compared, I personally believe there's good evidence that it's useful and has its place. Right, so this has been dry with no pictures, but I've got at least one picture for you. So this is a patient of mine who had been travelling, been overseas, had nasty adenoviral keratoconjunctivitis. She told me this, she's a nurse, she knew that the swabs come back positive for adenovirus and she needed steroid to settle things down. But on return to New Zealand, settling down, her vision had gone bad again, light sensitive, worse in one eye than the other. And so this is recurrent or resistant post-adenoviral keratitis, and it needs steroids again. And she got better, totally clear cornea, so all those dots go to nothing, acuity comes from 612 to 6.5, 6.6. But as soon as you start to taper to a weak steroid, which is what I usually do for that, so fluorometholone I think is a great drug, but as soon as we took it off the prednisolone, it just came back. And she then went travelling again for 6 months in the Northern Hemisphere before COVID. Somehow managed to get back to New Zealand just in time before lockdown. And I was getting emails saying, I've seen an ophthalmologist in Germany, he's taking me off the steroid. I say, okay, see how it goes. And then a week later, it's back, what do I do? So go back on the strong steroid. So the same pattern was happening, and we just couldn't get her off Pred Forte, and in fact, not below twice daily. So that's quite a big dose for a 26-year-old. And I started to have some misgivings, so you're going to get a cataract, even though her pressure was fine. So she came to me and said, why aren't you using this eye drop? And I was going, what do you mean, what eye drop? And I said, okay, that sounds great. I'm looking for something, is it cyclosporin? What about tacrolimus eye drops? So I'd use this in Australia for very complex multiple rejection graft patients who are having another graft, and we give them systemic tacrolimus. Bit controversial, but hey, there's heaps of money in Australia, we'll just give that to everyone. But never heard of eye drops. So she then emailed me all the references and said, have a look at these. So I said, awesome, okay. And very, very good evidence, reasonably recent, so 2017, 2019 evidence. And currently she is just paying for them herself, but they're not that much in the scheme of things for basically a chemotherapy drug. So when I saw her at a month after, it was magic, and she's tolerating the drops okay. She's a little bit stingy, but apart from that, she's not on any steroid and she's got no infiltrate. So in her case, very effective. So then I had to dig a bit deeper, and this is really what stimulated this talk as well as the interferon for me. I said, okay, what's tacrolimus? What's the evidence? So it is similar to cyclosporin, but a better inhibitor of those T cells. So there's one type of lymphocyte active immune cells. And you can make it up as ointment or eye drops. It does not cause a pressure rise, there's good evidence for that. As you might expect, you can use it kind of in all the situations where you might use a steroid, so it's a steroid sparing agent. You can use it for rejection, and I probably would use drops rather than systemic tablets now that I know this. You can use it as a sparing agent where you just want to avoid chronic use of steroid where you're getting thinning diseases. So evidence, Indian Journal of Ophthalmology, quite a big journal, 2019, randomised controlled trial, and not a huge number, only 45 in each side, but it was actually better than dexamethasone, and also less recurrences when they stopped it. It burns, so yeah, that's a minus. And of course the big thing here is pressure rise. So 15% of patients had a pressure rise with dexamethasone and 0 with tacrolimus. So a study back in 2017 with a reasonably long follow-up, 1 year, but it was retrospective, so that they were using that already. And that's in Cornea, again, big journal. And they compared, what I was interested in is the dosage in ointment versus eye drops, tolerability and efficacy. And they used ointment versus drops. And essentially the drops were better tolerated. So that's what we used in this patient, just eye drops. Yeah. So it's been a bit of a revelation for me, just an extra weapon that you can use in place of steroid, and it is available. So I of course sent the references that she gave me directly to Pharmac, and they just approved it pretty much straight away. Right, Avastin, we use it for so much stuff now in eyes, and it was originally developed, as you probably know, to treat melanoma as well, so it's given intravenously, about 400 times the dose of a standard intravitreal injection to treat melanoma. So it shrinks down the vessels in rapidly growing tumours. That's what it was originally used for. But it's great at switching off any vascularising process, which may include vascularising scarring. So, pretty good evidence. Avastin's been around for a long time that eye drops work. And they do reduce to minimise neovascularisation on corneas. The problem is they only work while you're applying them, and a patient putting in drops 4 or 5 times a day for months on end, it's not really a long-term solution. You have to get to the root of the cause. Why is there inflammation? Why is there scarring? Why is there neovascularisation in the cornea, I believe. So I've been doing this differently and using subconjunctival injection of Avastin. Sometimes it's remarkable, the vessels just go away, but you still have to treat the cause or stop stimulating the problem, say it's a contact lens or some sort of immune problem. So when they use drops, there was a problem as well. 1 out of 6 got a corneal ulcer, so in the longer term it's not that nice for the corneal epithelium. So I am not changing practice. I probably won't use drops much, just stick with the injections, which I do either weekly or monthly, and then monitor how they're going. And for that, because Avastin is so readily available, we have literally tens of them in the fridge. We can just grab one, and instead of sticking it in the eye, you stick it on the eye. So it's very readily available. So this year at the hospital, or last year, I had an unusual ulcer which came from one of Jim's patients. Didn't look like much, just non-healing, sort of whitish bits, but with an ulcer. And we took a while to getting around to scraping and figuring out that it was a very unusual bug, similar to TB. So it's a mycobacterium species, and like TB, it's highly resistant to like every antibiotic essentially. So I've never seen one of these before in 20 years, being exposed to cornea. We talked to the infectious diseases department at the hospital, which now has great mana because of COVID. And Sarah's a friend of mine who we kind of went through medical school. But I was amazed. She just said, why don't we just get some clarithromycin and amikacin eye drops, and we'll just throw those on and that'll be fine. I was saying, what? Never heard of any of this. Don't we just have Clausig? You know? And no, there's no problem if it's ordered by infectious diseases. We seem to have all kinds of problems if you ring up the pharmacy and say, oh, it's ophthalmology here. We want some weird antibiotic eye drops. And they're just like, oh no, we can't do that. If infectious disease is asked, oh yeah, that's fine. I'll just talk a bit more about that case. So what we ended up doing in this case, and there's a good reason why every antibiotic is not available as an eye drop, is that it turns out that amikacin, which is a aminoglycoside, it's similar to gentamicin or tobramycin, is reasonably well tolerated, similar to gentamicin or tobramycin. So gentamycin's a bit nasty. It gives you punctate keratitis after a while in everybody. We have actually moved to tobramycin for our nasty corneal ulcer protocol at the hospital because we think there's a little bit less surface toxicity while being the same sort of range of killing bugs. But I was surprised to find this was really well tolerated as well. On the other hand, the clarithromycin was just nasty for the eye, so she couldn't use it for more than a week or so, and we ended up giving her tablets instead of the same family of antibiotics. So there is a reason why we don't use every type of antibiotic in the eye that's specifically tailored to the bug that we're using. But you can make pretty much most things in an eye drop. Except marijuana. You can't make that in an eye drop because of something to do with the lipid solubility or something like that. So if anyone asks you, it doesn't work. Thank you.